If a patient were to walk into a clinic complaining about knee pain, the first question I would ask is where the location of pain is, and their response should be on the medial or inside aspect of the knee, either on, above, or below the joint line, depending on the damage done to the patient. And asking this question first right away can help narrow down if it's a posterior, anterior, lateral, or medial knee injury. So asking this question and having them say it's on the medial side immediately rules out any of the other three options. Next, I would ask about their prior knee injuries, if they've had any. And for second degree MCL sprains, they don't typically have a previous knee injury, but if they did, or if that's what this patient has, it does predispose them to getting a tear in the future. I would then ask about their type of pain, and it could be throbbing or sharp pain. And I would ask if they heard any sounds when the injury occurred, and their response should be no, they did not hear any sound, which would rule out a meniscal injury and a typical grade 3 sprain. And they should also have significant pain for a grade 2. So if they do say they have significant pain, then that would also rule out a grade 1 sprain. I would then ask if the injury is acute or chronic, and they should say that the injury was acute. I would then ask how the injury occurred, the mechanism of injury, and they should say that they were hit with a valgus force to the knee, or how they would say is they were hit on the outside of their knee, which is the more common mechanism of injury. Or the less common they could say is that they had their leg planted with an external rotation on the tibia. And having this mechanism of injury rules in a MCL sprain. The next part of this assessment would be the inspection. And when doing inspections, it's always important to make sure that you're doing it bilaterally. So comparing the injured leg with the non-injured leg. That way, with the non-injured leg, you can kind of get a gauge of what their normal is. That way, when looking at the injured leg, you can tell how significant some of the damage can be. So something you can look for is their gait right off the bat when they first come in. And there could be instability when they're weight bearing if it's a grade 2 sprain. And they would also have an increased pain during the mid-stance of the gait. And they may have a limp in order to protect their knee from the injury. And they would have an antalgic gait secondary to the pain and instability. And then when looking at the knees bilaterally, the injured knee could have mild swelling and bruising compared to the non-injured leg. And during the inspection, you probably wouldn't find remarkable results to rule in if it's an MCL injury right away. But you can tell by the amount of swelling that can happen, and also the amount of swelling can dictate what type of sprain it could be. And also if they do have a limping gait, you can definitely rule in that they probably would have a grade 2 injury. The next part of the assessment is to palpate. Always be sure to palpate bilaterally. So when looking for the medial injury, the first thing you should do is find the MCL. There should be tenderness along the length of the MCL from the origin to the insertion. First, have the patient in knee flexion, as it is the best position to access the MCL. Then you want to find the joint line. From the joint line, you move medially to the medial femoral condyle where the MCL originates, and then you would palpate down to the medial tibial plateau where the MCL inserts, and you would palpate this up and down and there should be tenderness while palpating. Next, we're going to do the range of motions, starting with active range of motion. We're going to do flexion, extension, internal and external rotation. For flexion, you want your patient to be laying supine, and you're going to instruct them to bring their heel as close to their butt as they can, and do this bilaterally. For extension, you want your patient to also be supine, and you're going to instruct them to push their knee towards the table, and ideally their heel will lift off the table when doing this. And be sure to do this bilaterally. Another thing to look for when doing flexion and extension is to watch how the patella moves during each motion. Have your patient go into extension and flexion bilaterally and watch how the patella moves. During extension, the patella should move up and laterally, and during flexion, the patella should move down and medially. Next, we're going to do internal and external rotation. Your patient should be seated with their legs free hanging over the table. You're going to ask your patient to bring your ankle out for external rotation and in for internal rotation, and make sure to do so bilaterally. Something you may want to do as a clinician is hold down at the ankle and measure what is ankle inversion and eversion and true tibial inversion and eversion. During active range of motion, pain with possible loss of motion can happen during the terminal ranges of flexion and extension, and a greater loss of range of motion can occur when the MCL is torn proximally to the joint line because there is a greater capsular involvement. The next part of the assessment is passive range of motion, and for MCL injuries, it would just be flexion and extension. For flexion, your patient needs to be laying supine, and you want to grab them just above the ankle and bring their heel as close to their butt as you can. And the other hand, you can put on the joint line of the knee and palpate it while you're doing this passive motion. For extension, your patient will also lay supine, and you want to fixate the femur above the patella and grab just above the ankle posteriorly, and you want to do a passive extension motion. And pain is possible as well as loss of motion at the end range of passive flexion and extension. Next, we're going to do the manual muscle testing. And a quick note for manual muscle testing is there is a decrease in flexion and extension strength secondary to pain, with flexion being more painful than extension. First, we're going to talk about knee extension. You want your patient to be seated with the leg midway between flexion and extension, and the clinician will stabilize the distal femur. The resistance will be at the distal tibia proximal to the ankle. For knee flexion, the patient should lie prone with the leg midway between flexion and extension. The clinician should stabilize the femur. The resistance will be at the distal tibia. You can internally rotate the leg to emphasize the contributions from the semimembranosus and semitendinosus. If you externally rotate the leg, you can put emphasis on the contribution from the biceps femoris. For isolating the sartorius, the patient needs to be seated with their hip in slight flexion and externally rotated. The foot of the testing leg should be on the medial tibia of the opposite leg. The resistance should be on the medial aspect of the distal tibia and ankle, and distal femur to prevent hip flexion, hip abduction, hip external rotation, and knee flexion. When doing the manual muscle test, be sure to always do it bilaterally and always use the same hand to do the resistance movement. That way you can have an accurate reading for the grade of 1 to 5 strength. The next part of the assessment is the special test. First, you would do the Salcombe drawer test for laxity of the anteromedial capsule. The patient should be supine with the knee flexed to 90 degrees. The clinician would sit on the patient's foot with the tibia externally rotated 15 degrees to isolate and test the anteromedial capsular instability. The tibia is then drawn anteriorly or toward the clinician. A positive test would be an increase in the amount of anterior tibial translation compared to the uninjured leg or lacking a firm endpoint. Implications for this test are damage to the MCL and anteromedial capsule. Be sure to do this test bilaterally. The next test for an MCL injury is the valgus stress test for MCL laxity. The patient should be supine with the involved leg close to the edge of the table. The examiner would stand laterally to the involved leg. One hand would support the medial portion of the distal tibia, while the other hand grasps the knee along the lateral joint line. To test the entire medial joint capsule, you should keep the knee in complete extension as depicted in image A. To isolate the MCL, you should have the knee flexed to 25 degrees as depicted in image B. Medial or valgus force is then applied to the knee with the distal tibia moved laterally. A positive test would be an increase in laxity, decreased quality of endpoint, and or pain compared with the uninjured leg. Implications for this test for the complete extension of the knee is a MCL sprain, medial joint capsule, cruciate ligaments, and distal femoral epiphyseal fracture. For the knee flexed at 25 degrees, it would implicate a sprain of the MCL. It would be good to do a complete extension and 25 degrees of flexion. That way you can rule out a distal femoral epiphyseal fracture and rule in that this is a sprain of the MCL. Be sure to do this test bilaterally. The vascular screening for a second-degree MCL sprain should come back as normal. For a patient with a second-degree MCL sprain, you don't have to do a sensory screening or neurological screening because they had not complained of any burning or tingling during the history portion of the assessment, and none of the tests ruled in that it was a neurological injury. So you don't have to do a neurological screening, but you can always feel free to do so if you want to be on the absolute safe side. Another thing is that you could recommend them to get an MRI, or if they'd already gone to a doctor, will have an MRI that could also help rule in or out if it is an MCL sprain, meniscal tear, or any of the other knee injuries.